Hello, everyone. We're going to get started. My name is Naomi Schumann, and I'm a CSPC Program Committee member. I can't hear you. I'd like to acknowledge that the Canadian Science Policy Conference is taking place on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation, whose presence here reaches back to time immemorial. We respect our traditional hosts and thank them for allowing us to operate on this land. We are about to participate in an interactive panel titled Machine MD AI for Our Future Health, organized by the University of Ottawa. Please don't forget to tweet about your favorite events and panels at the conference using @CSPC and hashtag CSPC 2022. Finally, don't forget to fill out the evaluation survey for this session in the program app. And without further ado, I'm going to turn it over to Andre Picard, the Globe and Mail health reporter who is going to be moderating this session. Thank you.
Thank you, Anne. We have some challenges in healthcare. You may be aware of that, including an aging population, technological advances, a shrinking workforce, and much more. Part of the solution is going to have to be greater efficiency. So can artificial intelligence be a catalyst for innovation? We know that in theory, AI has the power to revolutionize how patients are diagnosed and treated, and also change how we do research, especially how we test new drugs and medical devices. There's a lot of hype about it. A task that takes a doctor or a researcher many hours can take seconds with a machine. But our ability to analyze that data quickly depends on these machines. And we know the old saying, garbage in, garbage out. So there are challenges. And beyond the technical, there's issues of legal issues, ethical issues, privacy, data mining, et cetera, et cetera. And when machines fail, who takes responsibility? It's hard to imagine a future with AI, without AI, though. But the challenge is to do it right. That'll take a lot of human intelligence, and that's what we've done today. We've gathered a lot of human intelligence on this panel to talk to us about some of these challenges and the possibilities of what's coming. There's going to be 7 brief presentations, followed by a question and answer period. We also have several polling questions, so be sure to have your event mobile app at the ready, and hopefully the polling will work out. All of us are nervous about that, but we'll see. So let me, without further ado, introduce the first speaker, Dr. Colleen Flood. She's a professor at the University of Ottawa and a university research chair in health law and policy. She's also the inaugural director of the University of Ottawa Centre for Health Law, Policy and Ethics. And there's much longer bios on your app, but I'm going to keep them very brief so we can hear our very smart speakers. Colleen?
Bonjour, thank you very much, Andre. Lovely to be here and on our first snowy day in Ottawa. I'm glad that you could come out. I'm just going to briefly introduce this project, Machine MD. The collaborators that are part of this project are your speakers today. So I'm just going to tell you a little bit about that before we launch into it. As you'll see, we are a multidisciplinary team of clinicians, of innovators, of lawyers, ethicists, and policy scholars who are working in the area of the governance of health-related AI. And we're thrilled that to have received funding for our work from the Alex Trebek Society and Foundation here at the University of Ottawa. We're very thankful to them, to the Canadian Institutes for Health Research, and to CIFAR. So thank you for your support. We appreciate it a lot. And our various centres at the University of Ottawa, including my Centre for Health Law and Policy and our Centre for Law and Technology. Okay. So our mission is to try to move past discussions of the hype and to move past people's sort of initial visions of, Terminator as a doctor, and to try to get down to the actual specificity of different AI innovations in healthcare, what they are, what the challenges are, and what, if any, changes are needed in our governance mechanisms. So we are diving in deeply to ask questions of, is our current set of laws and ethical guidelines, are they up to scratch to deal with health-related AI and machine learning as it's coming into our healthcare systems? Do we need law reform? And what would that law reform be? And so we're striving to do this in a variety of ways. We're doing a large scoping review, looking at what everybody has said from different perspectives, clinicians, innovators, lawyers, ethicists. This is a very large body of work that we're doing to see what they see as the major legal challenges and what they see as priorities for law reform. We're also have written around things such as whether an overview of whether current laws are sufficient. We have been reviewing our existing laws around the regulation of medical devices with AI and whether they are up to snuff. And then importantly, and what you'll see a little bit today, we've been doing case studies, working with innovators who bring to us their health-related AI innovation, explain to legal scholars, ethical scholars, policy scholars, how the innovation really works, and so that we can understand it better and then have something more specific to say about, okay, what are the worries that we have from a liability perspective, from a privacy perspective, from an informed consent perspective? Are our laws sufficient to meet the challenges of this innovation? So we've been doing a bunch of these. So you're going to hear shortly from Devin Singh about his technology that he's worked on at Sick Kids. Joelle Pinot has been working with us on hospital resource allocation in the context of COVID-19. Black box surgical support tool, Frank Radatz and Theodore Grachanov, formerly at the University of Toronto, has worked with us on this. You're going to hear from Zachary soon on his suicide artificial intelligence prediction heuristic. The digital twin, our colleague Professor Abid Al-Sadiq, we worked with him on that. Cardiac arrest prediction in pediatric ICU. Anna Goldenberg, who's one of the co-leaders of this initiative, worked with us on this one. And then coming up, we're doing a case study on the robotic wheelchair with colleagues from Montreal. So the various case studies we write up, and they're available on the CIFA website. So if you're interested in reading more about some of the others, we'd be delighted for you to check that out and check out our website. So I'm going to hand it over, I guess, back to Andre, to introduce Devin.
Great. Thanks, Colleen, for setting the stage for us. Our next speaker, as you heard, is Dr. Devin Singh. He's a practicing pediatric emergency physician at the Hospital for Sick Children. Imagine you're pretty busy these days. Thanks for joining us anyhow. He is also the physician lead for clinical artificial intelligence and machine learning, again at Sick Kids, and the Division of Emergency Medicine at that hospital. He has a master's in computer science from the U of T, and he recently founded Hero AI, an innovative startup lab. So, Devin.
All right, thanks everyone for the opportunity to be here and to speak to you today. I'm really excited to tell you about this idea of machine learning medical directives. It's an innovation that we've come up with at Sick Kids to try and help drive real-time efficiency in our emergency department to really expedite the way we deliver high-quality care. And I want you to take a look at this kiddo here. It's the first snowfall day of the year, and he should be outside playing with his friends, running amok. But unfortunately, he's laying in his bed. That's a red flag. He's complaining of tummy pain, he's grabbing at his side, and his parents need to decide, are we going to just watch him at home? Are we going to maybe call telehealth? Are we going to bring him into the emergency department? And you know what? His pain's increasing throughout the day. Seems a little bit febrile, has a bit of a fever. So they come into the emergency department. And what actually happens in the emergency department right now? Well, when you come in to the top right here, your data is put into an electronic health record system. And I can tell you as a physician, when I look at that little snapshot of data, that you probably need an abdominal ultrasound, or you probably need a urine test or an x-ray. Like, we have a really good idea of what your needs are going to be. But despite that, you go into a waiting room area. You've got to wait for someone like me to free themselves up and for a room to become available, which is a huge issue right now in Canada. And that might take 4 to 8 hours, unfortunately. Now, the spoiler alert here is this kiddo does have appendicitis. Every hour that goes by, his appendix is getting bigger and bigger, and if we take too long to get him to surgery, it might rupture. After we see that patient, we get the ultrasound ordered because, of course, we want to rule this out. We take a few hours to actually get the result, and then we have to communicate and coordinate all of these different teams on the bottom. You know, diagnostic imaging, the general surgeons, the OR. Do we have OR nurses ready? Is there an OR space booked? Is there an inpatient bed available for this kiddo after we make that diagnosis and after the surgery, right? This gets complicated, and even when we've made the diagnosis, time goes by for us to actually get that kiddo to the definitive care. So we asked ourselves this question: could we use that triage data, that little snippet of text, that bit of the vital sign data, to encode that into a machine learning model and predict that this kiddo is going to need that ultrasound, and then just order it while they're waiting? So we took all of this triage data here, vital signs, demographics, age, presenting symptoms, and we plugged them into 3 different types of machine learning models. You know, these different types of algorithms, just think of them as like different cars trying to get you to the same location, right? It's 3 different methods for trying to do the exact same thing. Look at that triage data and predict, does this kiddo have appendicitis? And if so, let's order the ultrasound. And if we look at the overall methodology, we're taking this data out of our EHR, we're pre-processing it, which just means we're preparing it for a machine learning algorithm. We're then going to plug them into those 3 algorithms and make that prediction. Yes, I think you have appendicitis. No, you don't have appendicitis. And what I'm arguing here today is if the model says yes, let's just order the ultrasound without a physician in the loop. It's interesting. And so here's just a snapshot of what looks like a boring graph, but I know that there's some people out in the audience who really like to see the raw results and the raw data. So this is what it looks like. This is an AUROC curve. And on the vertical axis, it's showing you the number of true positives that we're able to capture. But notice that there's a trade-off. If I want to get 100% of the kids who have appendicitis, I want to diagnose 100% of them, there's going to be a lot of false positives. If you actually walk over and go down, there would be 0.6 times all the kids who come in would be the false positives. That's thousands of kids. Can you imagine what the radiologist would do if I just implemented this and started sending thousands of false positive cases? It wouldn't work, right? I need Secret Service to protect me from them. And so it's obviously not going to work. But what we recognized was, well, let's just play a little bit more of a humbled game here. Why don't we try to automate 10%, 20%, where the false positives are really low? Well, we're going to miss a whole bunch of kids, but now we've got to figure that out. How is that going to fit into the workflow? But if we do play in that space, the number of false positives is incredibly low. And when the model says, yes, you need an ultrasound, you really, really need an ultrasound. And then we realized we could do this for lots of things, like ordering forearm x-rays, doing basic ECG orders. You know, you might say urine testing, big deal. But if you've got a 3-year-old and you try to convince them to pee into a cup, it literally takes hours in the emergency department. It's a whole song and dance process. So getting that order placed right from the get-go is helpful. And so then we end up with this augmented workflow. Come into the emergency department. Your triage data is now on the bottom, plugged into our machine learning algorithm. If the model fires, we know that the false positive is going to be very low because we're calibrating our model to be that way. Just order the test. I mean, effectively what I'm saying is, can we give medical legal authority to a machine learning algorithm to provision publicly funded care to a child? That's the real juicy part. I'm standing up here saying, just order the test. But when I meet with people like Colleen, she challenges me with, well, can we actually do this, right? Do we have the pieces in place to actually regulate this type of work? You know, my models are adaptive, right? Do we have the pieces in place to ensure that we have the right bias assessments done, that we deliver this in an equitable way? And when you look at this workflow, if we miss a kiddo, well, we're not going to send them home. We're going to send them right back up to the normal standard of care. And that's sort of our safety mechanism there. So I leave you with this, what I think is a really promising project, but lots of key policy things need to be laid out for me to then translate this into action. And I'll end it there. Thank you.
Well, thanks, Devin. Quite a fascinating presentation with some good questions that I'm sure there'll be more questions about in the question period. So now it's time for the first poll. So I'm going to read it to you. You can see it in your app, but I've got to pass the time while you answer, so I'm going to read it. Do you think we should allow a well-validated AI model to automate test ordering for patients without a physician in the loop? So the important question that Devin just asked. Choose an answer. Yes, no, not sure, or D, it depends. And don't all be Canadians and say it depends because you don't want to take a public stand, but take a stand. So we'll wait for those results to come up, and there we go. It looks like the yes is narrowly ahead, but we'll go. So while we're doing that, while we're looking for the poll results, I will introduce our next speaker. Dr. Zachary Kaminski is the DIFD Mac Gallenstein Chair in Suicide Prevention Research at the Royal Institute of Mental Health Research, which is affiliated also with the University of Ottawa. Dr. Kaminski's lab does all kinds of interesting things, researching psychiatric conditions side by side in both animals and humans. And he focuses on the molecular epigenetic underpinnings of psychiatric illnesses, and with the hope of developing really bench-to-bedside translational findings, so really practical stuff. So, Zach, the stage is yours.
All right. Thank you very much for the kind introduction, and thanks everyone for the opportunity to come here and talk to you today about our work, the Suicide Artificial Intelligence Prediction Heuristic, which is quite a mouthful, and we actually honestly named it that so that we could call it SAFE. Sounds like a good, but I've gotten some criticism. Other people don't love the name SAFE. If we could advance to the next slide, that would be fantastic. Am I to do that with this? Oh, there we go. Okay, thank you. Something we didn't cover. So, all right, look, we know that suicide is a major public health problem. Rates have been stable for decades, over 60 years, and in fact, there's been an uptick, even independent of the pandemic. Just to put it in perspective, it's the second leading cause of death in young people, and we also know it's like crashing a 747 every year in Canada. So it's a big problem. And people have posited that, hey, if we could only predict who's at risk, then we could intervene in intelligent ways and try to reduce these rates. So we've attempted to build SAFE, which is a natural language processing method to guess who is likely to be at risk for suicide. And we've done this utilizing social media data. So the algorithm effectively looks for speech patterns before someone is at risk for suicidal thought and gives us an indication of risk. And we've used Twitter data because it's out there. It's public. And if you sign on to Twitter, you probably didn't read this, but it said, hey, public health agencies may download your data and use it to come up with new algorithms. So, we gathered thousands of people, and some were mentioning suicide, others weren't. And we created this approach that effectively uses neural networks to recognize concepts that are associated with suicide based on psychological models. So we ask for a given tweet, is this a lonely tweet? What is the score between 0 and 1 of perceived burdensomeness? What about stress, loneliness, insomnia, hopelessness? And we get these matrix of numbers. So we're not actually reading anything that anyone says. If you go through and you read a year's worth of someone's tweets, you can find out if someone is likely in a bad place. But who has the days to read through? This can do it in seconds. And then training a random forest, we get this guess as to if a tweet is at a high level and if someone's likely to be at risk of thinking about suicide. And now, if we take this model and we actually slide it over someone's whole social media timeline, we iterate it over all the posts, we can actually generate a picture, which is pretty interesting. So just imagine you're looking at a year's worth of someone's data. They're good in the summer, and in the winter, you've got this hill that goes up into December. And they might have seasonal affective disorder. We can see that sometimes in women, we see premenstrual dysphoric disorder if we see a cycling of the pattern. So beyond suicide prediction, we get hints as to other mental illnesses that could be at play. What about suicide prediction? How does the model do there? So we're getting area under the ROC curve of around 85% in the original study, and we just submitted a replication paper yesterday looking at 2 cohorts in Canada, population-based and students, and we're getting around 80% accuracy. So that sounds great, but I want to point out a problem. It was mentioned in Devin's talk that false positives are something to consider, and suicide is a low base rate problem. In Canada, it's 11 per 100,000. So just imagine a perfect test, 99% sensitive and specific. That 1% of those 100,000 is 1,000 false positives. So you might find all the 11 cases, but you're going to have 1,000 false positives to deal with. Now, those numbers get a little bit better if we try to predict something less severe, like suicidal thought, but not death by suicide. And so here we might catch all 11 cases, but still have 20 false positives to deal with. So it's something to keep in mind. And as we talked about bias a moment ago, we looked at that in our algorithm. We noticed that sex and gender is not biasing our algorithm, but we saw better performance in younger users. So we need to keep that in mind. It sort of follows the trends of the Twitter users, which just goes to show that the more population representation in our training model is going to bias the algorithm towards who we're going to be able to predict. So as we use the algorithm in the future, we may get less confidence if we're using it on someone who is older, and we need to keep that in mind. So how might we use this? Well, I see a lot out there in the literature. It's like, oh, if we can predict who's at risk, we're done. We can stop. But we need to consider how we might use an algorithm that tells the future. So one possibility is at point of care. Someone is brought in by the police, for example, for a mental health evaluation in the hospital. Well, right now, we don't have any tests other than in mental health and suicide, other than asking someone, how they're feeling and if they're at risk and if they have a plan. So we might be able to use this picture of if someone's been distressed to augment that mental health assessment. But I think it might be important that there's a clinician in the loop. Because remember those false positives. What is our intervention? How invasive is that intervention? In the hospital, if you're going to be admitted, if you're going to be formed against your will, and if your story changes about your suicidality, which I can tell you from experience, it does for people, then, what are you going to do to manage those false positives? What about triaging people on wait lists? We might be able to use this to say, hey, these people need help first. But we need to consider the ethics of people gaming the algorithm, right? If people realize they might be able to skip those year-long waits or 6-month waits to get into care, then this might be something that people might try to take advantage of. And so one area where we think this might be really efficacious is if we change the nature of the intervention. What if we made the intervention less invasive by using this ability to see the future? So we can think of this in 2 ways. One would be for people being discharged in the period after discharge. Transitions are a dangerous time for people. But what if we could build an app that monitors people, and then as their risk begins to go up, we act, but with a lighter touch before people are in a period of distress, before they're in crisis. And thus, we may be able to use a less invasive intervention. So we've actually, I should mention, we're creating a startup company that may build this. Effectively, people might select confidants in their network. What if you could show people you trusted your data, and they could be digitally prompted to reach out, but before you are in that period of crisis? So we want to evaluate this more tolerable intervention. But we need to keep in mind, again, the law and the ethics. Once people have access to your data, we need to, it's easy to keep looking at it. We need to have people be able to turn off their data if they're no longer interested. What about having consent to data? So we want to make sure we use this, even though Twitter IDs are public and we can find them. We don't want to use this against people's will. People should consent to the type of data that's going on there. The last thing I have there is that we can sort of use this in a less personal way and look at the population level risk by assessing suicide risk in geographic areas. But really, it's the individualized methods that we're interested in. So I'm going to stop there, and thank you very much for your attention.
Oh, thanks a lot, Zach. As someone who spent far too much time on Twitter during the pandemic, I can tell you that every tweet is a sad tweet. So you can take that to the bank. So it's time for question number 2, our polling question number 2. Would you feel comfortable having a healthcare app use your social media data for healthcare purposes, especially after what you just heard? Choose an answer. A, yes, B, no, C, not sure, and D, it depends. Okay, well, we've got a close race between yes and no on that one. So I'm going to invite back up to the stage Dr. Colleen Flood. She's already been introduced, so I won't introduce her any further.
So I think you can see that one of the reasons that we're doing these case studies is because the 2 examples we had have very different perhaps risk profiles, and perhaps as evidenced by your response to how comfortable you are with one as opposed to the other. So we're trying to, build a big bank of these actual examples so we can really dig deeper to understand the legal ramifications. So I'm just going to speak briefly about liability questions, which we see as a very big concern for innovators, for clinicians, and then potentially for patients who might be harmed. And then we are going to have my colleague Catherine is going to talk about informed consent, and Teresa is going to talk about privacy, and then Tanya is going to talk just briefly about education of clinicians. So just on the question of liability, the hope and the expectation is that AI will improve upon quality and safety. And many Canadians suffer as a result of medical error each and every day. So we can't be too romantic about human decision-making in this regard. But if AI is incorporated as a standard of practice, is used across a variety of domains. One could imagine, for example, assessing X-rays or MRIs, right? It's just a normal thing that is done each and every time. Although the number of times that an error happens may reduce, the scale of the error could be very widespread. So many patients could be affected if an AI tool in the future goes wrong. So we do have to think about the consequences and liability as a result. And we've already heard from Zachary, we know that high quality AI and machine learning needs to be built on high quality data. And yet if AI and machine learning tools are built on incomplete or biased data, then there is a greater chance when applied to patients who are not represented in the data that there could be an error in the diagnosis or in the treatment decision. All right, so those are the risks that we're dealing with. So when we're speaking of liability, we are normally in the realm of what pointy-headed lawyers call private law and specifically tort law. And tort law is part of common law. Common law is judge-made law. So these are decisions rendered over time by judges, and we build up a bank of references or precedents, as we call them. And tort law kicks in after an injury has happened. It works to provide compensation to patients who are injured because of medical error, and the hope is that doctors, hospitals, nurses, and so on, seeing these kinds of claims will take more care and be deterred from making similar mistakes. But to be clear, the vast majority of patient injuries do not result in compensation. Because even if an injury does occur, and even if patients have the energy and the money to sue, provided that they have no recourse, provided that the healthcare provider has met the standard of care. And so that is to have done what is normal and reasonable in the circumstances, and then no liability flows. Further, if the patient would have received or been inflicted with the injury anyway, if the court considers this, there's no causation, then the patient cannot succeed. So the vast majority of times that a patient brings a claim, they are not successful in an argument for tort liability. So one of the questions that does arise at the outset on liability frontier is whether as new health-related AI technologies are used in the healthcare system, whether hospitals, physicians, and other healthcare providers will be found negligent if they don't use AI. So as AI starts to come in, it's new and it's sort of understandable that perhaps physicians may not employ it, but over time as it becomes the standard of care, then will physicians be found to be negligent, to have made an error by not using it. An example here is NarxCare, which is a prescription drug tracking tool used in the US to predict risk of substance abuse or overdose following opioid prescribing. And American healthcare providers are required to follow the tool's direction, or they can lose their medical license if they fail to do so because of all the problems of overprescription of opioids. So here you have an AI tool basically being used not only as a standard of care, but actually as a guideline for regulation. And you can see that a similar tension between clinical judgment and algorithmic prediction could arise when using the tool like the suicide prediction tool that we just heard about. So another issue relates, of course, to how to apportion responsibility or liability between different actors. For example, when an AI product fails or causes harm to a patient, how much responsibility or liability should flow to the innovator or to the manufacturer, as opposed to the healthcare professional who uses the tool and applies the tool to the patient. And a lot of folks in the humanities are of the view that it is important to keep the physician in the loop, right? The provider in the loop. And that's for a variety of reasons. Sometimes it's because they think that's important to ensure the humanity of care, right? That simply being treated by a robot is not how we should think about healthcare. Some folks are of that view. Sometimes it's a bit of self-interest because healthcare providers don't actually want to be replaced by robots, so it's a labor question. But it's also sometimes because they're of the view that humans need to oversee AI in order to be able to spot the mistakes. Although, of course, the risk here is that instead of catching errors, that physicians will supplement their own wrong analysis for that of the AI, and that keeping the physician in the loop will simply mean extra costs, right? So we keep the physician, we add the technology, all other things being equal, we won't be able to afford much more after that. And so physicians might feel very comforted by this idea that we're going to keep the physicians in the loop or the provider in the loop. But from a liability perspective, if they hold themselves out as having control or expertise in the use of the AI, then they may expose themselves to liability and responsibility if harm befalls the patient. So the patient will be looking to the healthcare provider then for their expertise as opposed to the manufacturer and innovator. And physicians need to be aware that manufacturers and innovators can avoid liability for their AI products if they include sufficient warning labels as part of the contract of sale. So lawyers working for manufacturers of AI and machine learning will, of course, try to construct these warning labels and contracts of sale so that the responsibilities for error will fall on the hospital or upon physicians or other healthcare professionals or patients themselves if they use this at home or in home care settings and so on. For example, it could be warnings about the data limitations, right? So that there are data limitations and that this could not be necessarily applied to certain subpopulations. And so I think physicians and hospitals taking all this into account really, and as we've sort of been advocating as part of this work, need to be wise and insist and lobby, really, the federal government and Health Canada to ensure that all health-related AI goes through very serious assessments prior to being launched onto markets, right? So we're not in favor of bureaucracy for bureaucracy's sake, but to make sure that good AI gets into healthcare systems fast and quickly, and functions well, and then particularly if it's adaptive AI, so machine learning, that there is a regulatory mechanism in place to make sure that this is evolving over time in a safe way and data is being collected about how it is working in real time. So that's me on liability. I could go on for a little bit longer, but I will get off the stage because there are many more people who have a few things to say. I didn't even click up here.
Great. Thank you, Colleen. You asked, how do we apportion liability? And we're going to get the audience to tell you. They're going to use they're all going to be learned justices and answer the next poll question, which is this one. If a doctor uses AI to make a diagnosis and recommend treatment and it's wrong, who should be liable for any injury suffered by the patient? A, the doctor, B, the manufacturer of the AI device, C, the hospital where the device is used, D, A plus B plus C, or E, A plus C. We just blame everybody for everything. It looks like D is winning, which is A, B, C. Everybody. Interesting. Okay, so let me introduce our next speaker. We'll mull that one over. Dr. Catherine Régie is a full professor at the University of Montreal Law Faculty. She's a holder of a Canada Research Chair in Health Law and Policy. She's co-founder of the Health Hub, Policy Organizations and Law, known as HPOD, and a founding member of Justicia Research Group, and also a researcher at MILA Quebec, which is the Artificial Intelligence Institute. Catherine?
That was you, Colleen, right? Okay, so hi, everybody. I know it's weird. I'm wearing my coat, but I'm freezing. So first snow day. So we're going to talk now about informed consent. So the big question here is, do patients need consent to the use of AI in their healthcare? So from a legal point of view, and there are different points of view, I'm going to cover some of them, but now from a strictly legal point of view, informed consent must be obtained for treatment purposes, so not for diagnostic or quality improvement, for instance. So before treatment is given to you, you must give your consent, and this is grounded in the right to integrity of the person. So therefore, when AI is used for treatment purposes, consent would then need to be obtained. And what does that mean on a practical level? So from a patient perspective, and you have that on the slide, so the patient would need to be informed about the nature of the treatment, the risk, we call this the material risk, the benefits, and the treatment alternatives, for instance. And also the physician would need to answer any questions that the patient would ask. So if the patient asks, well, what are the risks about, give me more detail about the risk of this AI tool for my treatment, the physician would need to answer that. So from the physician perspective, it's kind of the flip side, right? So the physician need to be able to give the information for the consent to be informed. And in the context of AI, it raises specifically complex questions because these tools are often opaque. So what should physicians say to the patient? How often he should say new information about the AI tool? And what kind of information they should have with respect to the AI tool they use? This is something that is not entirely clear right now, and this is why this project is especially important, I think. So, for instance, should the physician mention to a patient, well, I don't know how accurate the AI system could be for you, as it was mostly developed for people over 40, but it still has a 65% percentage of accuracy for your treatment, and I would like to use it. Should a physician ask, I'm going to rely on an ongoing AI inputs during your operation, do you agree? So considering this lack of clarity, what we need to rapidly define is what I call the green box for healthcare professionals in the context of AI. So that is what they need to know about the AI tool they use to use it appropriately and to give sufficient information about it. So this green box could involve having information about the type of data that were used for the AI tool, the variables that were considered in the AI system, what are the weak spots of this AI system, and for which group and patient it is more accurate, something that was mentioned before, and which group were excluded from the data, and so on. This, in turn, requires a sufficient level of transparency for the AI used in healthcare to use them safely and effectively. And for instance, there should be no confidentiality agreement between healthcare professionals and AI developers for the green box aspect. Now, going back to the main question of informed consent, we know from a legal perspective now that informed consent duty is limited to very specific context. So for most cases, AI will not be used for treatment options per se, so at least not now, but more for diagnostic and quality improvement. So probably there's not a lot of circumstances, at least for the moment, where a formal duty to obtain exists to obtain an informed consent. But this should not be the end of the story. First, the law could be changed, so we need to have this perspective view of how the law could evolve in that sense. And also, there are ethical aspects to consider. So the law defines whether we have to do it, but the ethics answer the question whether we should do it. Help us to answer that question. So, how the law could be changed? That's the first point. Just to give you an example, there's the French model. So the French have decided to enshrine in the law the duty to disclose the use of AI tools in healthcare for prevention, diagnostic, or treatment. And also the results have to be shared with the patient and the interpretation that comes with it. Issue resolved. They have a law, they decided, let's be very clear and upfront with this. So this could be an option, but that we need to discuss and explore this further. Second, regarding the ethical consideration. So one of the key ethical bases for informed consent is trust, and something that is mentioned in many code of ethics for healthcare professionals, as you might know. So is there something special about AI that demands physicians and caregivers more broadly to disclose for ethical justification when they use AI tools in their practice to maintain trust with their patient and towards the profession? I think that's a very important question. And there are some element of responses to answer that. First, I think it's partially an empirical question, and we will have a polling question about this. So it really is about whether it is important for patients, and that would influence their trust towards their caregiver or the healthcare system more broadly to know or not to know whether an AI tool was used. Obviously, this could depend on the context and what it was used for, so what place it takes in the decision, the AI system, and in the relationship between the patient and the physician. But more broadly, I think it's a very interesting empirical question that we should ask. Second, I would argue yes, I think there's something special about AI, at least in some circumstances. AI is a potentially powerful and transformative tool in the healthcare system and for the relationship that compose them. And one of the risks of AI for healthcare professionals is what we call the automation bias. So it's the tendency to overly rely on the machine, just like we do with Google Maps, right? So as Kasparov mentioned, the problem comes when the database and the machine go from Coach to Oracle. And this was also mentioned as the danger of having atrophy of human judgment and by digital innovation. And I think there could be a trust issue if we go in that direction. And this is a real risk. So AI tools can be especially powerful. They can be very accurate, sometimes even more accurate than physician. And it will become more and more often the reality. So it would be tough to kind of keep your judgment and not overly rely on the machine, knowing that it could be that powerful. And also it could be a huge time saver. So often we say that it will only be a tool for physician and caregiver. But will it always be the case? And whether the physician will be the tool for the AI eventually? I'm being provocative here. So I think to maintain trust, healthcare professionals should keep their critical thinking compass alive when they use AI. And education is a very key component for keeping that critical thinking alive. And I think we'll cover that with Danielle later on. And to be, again, a bit more provocative, so could the trust issue go the other way around? So towards the physician who do not use the AI, and then should they mention it to the patient? Should they have a sign on their door saying, no, I'm not using AI in this office, you should know, so maybe you want to go see another doctor. So just to say that to answer all these questions, we are working on this in this project, but also in Quebec, we are working on developing a model, a prototype for an AI code of ethics for healthcare professionals. And so we do this with almost every regulatory health colleges in Quebec and a group of researchers. So we are developing this model with specific sections that kind of define what we expect from a healthcare professional using AI in healthcare. And it's in the final stages, so it's out for commentaries among the regulatory health colleges. But just to give you a few examples, only 2 sections, that is going to be embedded in this code. So section 5 will be, and you'll see the link with what I've said before, the health professional must ensure that the use of AI and of an AI system in his or her practice does not come at the expense of establishing a relationship of mutual trust with the patient. And section 7 will be, it's a bit longer, but I think it's important. When proposing the use of AI in his or her practice, the health professional must have adequate knowledge of the possibilities and limitations of the AI, in particular to A, be able to provide sufficient information to the patient based on the risk involved so that he or she can make an informed decision about the care offered on that basis. B, be able to exercise professional judgment with respect to the use of AI results. And C, report to competent authorities the occurrence of potential incidents or problem related to the use of AI system. And I think to work with regulatory health colleges is a very strategic point of entry because they have more flexibility and agility than the legislator to adjust to this new reality and propose different modality and standards of care to their healthcare professionals. So I think it's a very important project, and it will be published so you will be able to have access to it. Thank you.
So you won't be surprised to learn that we have another poll question based on what Catherine just said. So we'll go to poll question number 4. Would you want to be informed if your doctor uses AI to make a diagnosis and or recommend treatment? A, yes, always. B, no, this is just one of many tools my doctor uses. And C, it depends. So strong showing of yes, but not overwhelming. Interesting. So brings us to our next speaker. Dr. Teresa Scassa is the Canada Research Chair in Information Law and Policy at the University of Ottawa Faculty of Law. She's a member of the Centre for Law, Technology and Society at the University of Ottawa as well, where she's part of the Scotiabank AI and Society Initiative. Teresa is the author and editor of numerous books, one of which is very relevant today, AI and the Law in Canada, published last year. Teresa.
Thanks so much, and lovely to be back in person at this conference. So I'm going to be talking about the privacy aspects or dimensions of AI. AI, obviously, and AI for health relies on large quantities of data, much of which has its origin as personal health information. Not all of it, but much of it is starts out its existence as personal health information. And so because of that large volume of sensitive personal information, there are obviously going to be privacy issues. The privacy issues arise in a context, I think, where there are competing tensions. And one is, of course, over privacy and the protection of personal information. The other is with respect to access to data that is needed in order to innovate in the area of AI, in order to produce high-quality AI systems. And so there is this tension, and I think that, that the older conception we have of privacy and privacy law is very much focused on privacy. But what we're starting to see now in the AI context and in the broader data society context is talk about things like data governance more broadly, which involve privacy, but also involve a range of other considerations relating to data. So privacy is now, I think, intertwined with many other data-related issues. Now, I've mentioned that the data for AI in health is typically or often starts out as personal health information. And personal health information in Canada in particular has had a particular legal meaning as data that comes from the healthcare system. But of course, it's important to keep in mind that increasingly information that is used in healthcare applications and AI come from other sources as well, including the private sector. We've heard, for example, about the use of social media data or Twitter data in the suicide prevention app. But there are many other private sources of data, including things like DNA, right? The Ancestry.com and similar services are becoming a source of genetic data about individuals. So the private sector is becoming an important supplier of data that are used in healthcare and that are not governed under personal health information legislation, but are governed under other regimes. So much of the data that's used in AI is de-identified or anonymized before use. Not all of it, but a large quantity of those data, or a large portion of those data, are de-identified or anonymized. In spite of that, there remain concerns about re-identification risk, particularly in contexts where data may be sourced from multiple different, or may come from multiple different sources, so that the use of those data from different sources in combination may permit the re-identification of individuals. So re-identification is an issue in this area, even if data are de-identified for use in AI. And I mentioned before that the sort of the broader field of data governance intertwines a variety of different issues. Some of those relate to data quality, and there is a relationship between privacy and data quality in that some of the techniques to protect privacy, including de-identification, may have impacts on data quality. And so there's an interesting tension between those two as well. Fitness for purpose. Bias and discrimination. Just because it's personal health information doesn't mean it's good personal health information or that it's fit for the purpose for which it's being used. And so those are important issues that are all part of this context or this landscape. And so, as I said earlier, increasingly privacy issues have to be considered within this broader context of data issues and within data governance more generally. Canada is increasingly challenged by its complex and outdated laws with respect to privacy or data protection. They're complex because we have multiple laws for multiple sectors and multiple jurisdictions. So, each province will have a public sector data protection law. Most provinces also have a personal health information data protection law. Some provinces, like Ontario, have municipal laws governing the protection of privacy in the municipal context. Some provinces, Quebec, Alberta, and BC, have private sector data protection laws. The federal government has a private sector data protection law that applies to interprovincial and international flows of data, as well as to intra-provincial flows of data in those provinces that don't have their own laws. So you start to get the picture. There's a lot of laws. And they're not all the same. There are some important differences between those laws so that there can be variations across jurisdictions. And so the proliferation of laws, the potentially different standards that are applied and different interpretations that may be applied can be challenging, particularly when there's a desire or need to work with data that come from multiple sources, or to combine data from multiple sources, whether it's public sector, health sector, and private sector, or whether it's across jurisdictions, or it's a combination of those things. It's the kind of thing that keeps lawyers in nice houses and nice cars. In any event, but it's not otherwise socially useful. data also comes from other jurisdictions and flows to other jurisdictions, and this can be a further complicating factor. And in fact, we do see data being sourced for use in Canada from the United States, and sometimes that's Canadian data that's being sourced from the United States from, for example, social media platforms or data brokers in the United States that are collecting it from Canadian sources. And that can be complicated, particularly where those other jurisdictions, such as the United States, do not have the same standards or levels of data protection. It can raise issues around consent to the use of the data, to the quality of the data, to the pedigree of the data. Where does it actually come from? How was it actually collected, and so on. The other thing about Canadian laws are that they are mostly outdated. Now, in fairness, it's hard to stay up to date. This is an area where there's been a tremendous amount of change and development. But for the most part, the laws are outdated, sometimes significantly so. Quebec is an exception. It's recently revised its public and private sector data protection laws. Other jurisdictions in Canada are at different stages of modernization of their laws. We have a bill before Parliament that will amend the federal private sector data protection law. We are told we'll eventually have one to amend the federal public sector law. Haven't seen that yet. And different provinces have taken different steps with respect to their legislation. But that's another thing to keep in mind, that there is also a significant amount of catch-up that has to take place federally and provincially with respect to the governance of data. In terms of, I thought I'd say something about, I've mentioned de-identification and anonymization. I think one of the trends that we're seeing in data protection law reform is to more directly address anonymization. It was certainly mentioned in laws in the past, but not necessarily addressed in a substantive way. The current trend where laws are amended is to include sometimes very substantial penalties for re-identification of de-identified personal data. And so, for example, this has occurred in PHIPAA, although we're still waiting for the regulations that will put in place administrative monetary penalties for misuses. But penalties for re-identification are included in PHIPAA, and they will be included in Bill C-27 if it's passed. The trend is also to consider the anonymization of personal information as a use of data that requires neither knowledge or consent. In other words, the trend is to have the laws facilitate the anonymization of personal data by saying it isn't necessary to get knowledge and consent of individuals to the anonymization of their data. It's seen as a privacy-friendly move because, of course, if data are anonymized or de-identified, then privacy is much better protected against breach and hacking and so on. But it does raise other challenges and issues as well. The trend is also in legislation to find that anonymized data are not personal information or personal health information, and therefore are out of scope of the legislation if they're done properly. That has raised some concerns, this idea that this data, which starts out as personal health information, leaves the governance framework of data protection laws if it's anonymized. PHIPAA allows for this, and so does Bill C-27, although there's an interesting twist with C-27 that I may talk about in a minute. This mobilizes data for use in AI, but it does, as I said, carry with it risks and challenges. One of those risks is re-identification risk. Another challenge, I think, that needs to be addressed, because we're seeing issues around this, is the issue of what I'll call social license, although I use the term carefully because I think it is misused as well. But it's the idea that there's public acceptance of the use of data in this way. And so if you think about the media uproar over PHAC's use of mobility data during the pandemic, you can see an instance where there may not have been any specific privacy issues, And this was a use that was being made in other jurisdictions of similar sets of data, but there clearly was not a sufficient degree of public awareness, public engagement, public knowledge, or social license with respect to the use of this data. And I think that raises really interesting issues for users of data, including de-identified data, as to what processes, what mechanisms do they need to put in place to ensure that the data uses are acceptable, the data uses of human-derived data are publicly accessible. I mentioned that Bill C-27 includes something a little bit extra with respect to anonymized data. Bill C-27 contains a new Artificial Intelligence and Data Act, proposed Artificial Intelligence and Data Act, that will provide for some governance of anonymized data that are used in AI. And this is, although the Act in general is designed for high-impact systems, these obligations with respect to data are broader than just high-impact systems. They seem to be applicable to all data used in AI. And the requirements, it will impose requirements regarding the use and management of anonymized data, as well as measures for anonymization. So that's something that's on the horizon. It's not clear, though, to whom this will apply, because there's provision for all kinds of exceptions, which might include certainly public sector actors, but possibly also actors in the healthcare sector. And it's also unclear when it will apply, because so much of the substance of the bill are being left to regulations, and that can be a very slow process, and it can also be a derailed process. So, it's anybody's guess what we'll see out of that. I feel like I've been talking for a long time. Maybe what I'll do is sit down. I was going to talk, there are a few other items on the slides, but they can always come up in discussions. I think I've said enough for now. Thank you.
And one last polling question for the audience. So, do you have any privacy concerns about AI-based medical devices or models that require access to personal information? A, yes, I'm very concerned. No, I trust that appropriate privacy protections are in place. And C, it depends. Okay, well, slight lead for no, but interesting. Now, before I introduce the final speaker, just a reminder, if you have questions, you can type them in the app. There's a Q&A function, or there is going to be a mic circulating shortly after the next presentation. Our next speaker is Tanya Horsley. She's the Associate Director of Research at the Royal College of Physicians and Surgeons of Canada. Yeah, very good. And faculty in the School of Epidemiology and Public Health at the University of Ottawa. Dr. Horsley also leads an emerging program of research looking into the formalization of integrated knowledge translation for the co-creation, use, and influence of research and complex systems of care. So, Tanya, the stage is yours.
There we go. Get organized here. Hello, everyone. If you had told me that Andre Picard would introduce me in my lifetime, I would have said no. So I'm going to thank Colleen for this generous invitation to speak to you today. So I'm going to situate my thoughts and comments a little bit. It's a bit of a 180 from what we've heard today in terms of the innovations and the case examples. But I think it's an important conversation to provide perspectives from an organization that sets the standards for evaluating, training, and certifying all specialists in Canada. So last time I checked, our organization has nearly 47,000 members. And you can imagine that the Royal College a few years ago understood that there was going to be a profound impact in the training and practice of medicine for specialists, and commissioned a task force to really think about how would we support the medical profession for this impact and introduction of health technologies and digital technologies. So they commissioned a task force that would inform and think deeply about recommendations that would set the strategic direction for how we would support all of our trainees, our residents as well as our fellows in practice. We also understood that other health sectors were ahead of the game. We had a question about where we were in the space. Is AI coming as a whimper, or is it coming in as a lion? And I think our task force told us it's already here, and we may be a little bit behind in our training and education. We also wanted to figure out how to develop monitoring strategies that would really help us understand those innovations that will impact specialty medicine now as well as in the future. Let me talk to you a little bit about what went into this task force, and then I'll show some of those recommendations. We recruited 14 global experts in AI, and the task force was chaired by Dr. Richard Resnick. I'll just keep going. We also did a lot of research and exploration in this area to set our recommendations. We did an annotated bibliography of nearly 30 global reports that looked deeply at AI, or the intersection of AI and health technology. We did 22 expert interviews with individuals like Bertalan Mesko, the director of the Futurist Institute in Hungary, or Yoshua Bengio, and some of the top experts in AI. Am I on the right slide? Okay, people are pointing at the slide. I just want to make sure I'm in the right one. And so we did interviews. We also did a survey and had nearly 4,500 of our fellows respond and let us know their education needs, their worries, where they felt they were in their understanding of AI. And some of those results are really interesting. Finally, we also invited 40 of our fellows who identified as experts, individuals like Devin, who might own a company or have direct training in machine learning or computer science. And we invited them to litmus test our recommendations before we provided them publicly. So if you're interested in the report, it's publicly available. You would simply search in Google, Royal College AI Task Force, and it's available as an executive summary and full report. So let me walk through some of the recommendations. So you may have heard this before. It's not new that AI will not replace physicians, but as Colleen mentioned, those who do not use AI when it becomes a standard of care may be replaced. And so the college has decided, and we have a say in the number of positions for training, that for now, we will not alter the number or complement of specialist physicians in Canada. However, we will monitor the health of specialties because there are some that have been perceived to be at risk, for example, radiology. And what we've heard from radiologists is that as a radiologist, the more I learn about AI, the more I realize my job is secure. We also would consider introducing a discipline, what we've called now clinical informatics. And that is designed for specialists who have an interest in diving more deeply into a technology focus in their training and practice. And the idea is that we would develop a cadre of specialists across Canada that could support in institutions. We also want to play an active role in supporting fellows to co-develop and validate the spread of AI. We believe that responsible AI, the best technologies, will be developed not only with computer scientists, engineers, and mathematicians, but it must include physicians at the coalface. And so one of our recommendations, where we'll be investing some time and energy, is about responsibly promoting collaboration between fellows and industry. How do we do this well? Conflict of interest is not bad, but how do we manage conflict of interest that's healthy and productive in these relationships? Now, Bertalan Mesko is someone who we engaged as part of our task force. And one thing he really stressed to us is as physicians gain access and learn more about their health data and bring that health data to physicians, it will be truly the democratizer of healthcare, that it will really even the playing field between physicians and their patients. And so we need to implement mechanisms to include patients' perspectives in all facets of AI-related decision-making, ensuring multiple diverse perspectives at the table. And I can tell you at the Royal College, inclusion of patients, not only in AI, but across all decisions, is now becoming our norm. And the truth is that this idea that you're in training once and out and catapulted into a 40-year career is no longer going to be a reality. In fact, what we've heard from some of our experts is that you will go out of training and you may transition careers 2 or 3 times. But there's a matter of urgency for the Royal College. In partnerships with its sister organizations and others, there's a recognition that we currently do not have efficient mechanisms to train, upskill, and retrain our 47,000 fellows that are currently in practice. So we need to provide support to developing these new competencies and in facilitating these career transitions. And finally, from an education lens as well, we know that the introduction of AI and digital health technologies provides great promise, but there's also potentially great peril. So this may exacerbate the digital divide, particularly in marginalized populations and those that are underserved. And so understanding that data may not be presented in these models and ensuring that physicians understand this, we are making a deep commitment to knowledge translation, that we need to support scholarship to increase physicians' knowledge about social justice implications of AI-based technologies. So I'll end there, recognizing the last person always has the shortest time, but I welcome questions going forward. Thank you.
So we're going to cram everyone into this small table. If you have questions, there's a mic circulating around. Just raise your hand. We don't have a lot of time. We're cognizant we're standing between you and lunch, but we'll try and cram in a few questions. And I want to start with Zach, if I could, because we had a question for you. The person has to be rewarded for asking the first question. Given that people are notoriously inauthentic on social media, how do we adjust for that when looking at the data from it?
Yeah, no, thanks. That's a great question. I think, all we can do when it comes to answering something like that is look at our evaluation data, and we are showing that the model surprisingly picks up patterns that people don't necessarily know they're putting out there. So we've run it on people anecdotally. They're like, there's a peak, and they're like, oh, that's when I had this really bad, health diagnosis. But I didn't say anything about that. So I think despite people trying to game the system and the fact that we validated this externally against psychometric scales, the performance is what the performance is. It's picking up what people are saying. So maybe that's the power of AI. Thanks.
Great. And Devin, I want to ask you on this issue of false positives that you talked about, is it going to resolve itself over time? More data just makes us better? Is that just going to take care of itself or no?
A little bit. If you're trying to combat false positives, yes, building a more accurate, robust model will help. So more data access, resolving some of these privacy barriers that can improve data access then may lead to a better model. But there's always going to be false positives. Nothing is perfect. Even myself as a clinician, think of all the ultrasounds I send to diagnostic imaging. Majority are false positives in my pursuit to find that positive case that needs a surgical intervention. So really the clever part here is how do we craft clinical workflows that are really rooted in human perspectives that then allow us to mitigate those false positives.
Okay, great. So let's go to a question live. Go ahead.
Thanks so much. So kind of 2 parts. The first part is, I wonder from a public relations or communications perspective if AI or artificial intelligence is still the best term to use when we know most of it's actually machine learning or regression models. So I wonder if going to patients saying artificial intelligence, someone made the comment, it's like a cyborg up there who's treating you, when in fact, and I think you guys have all mentioned this today, is that it's still your doctor who's treating you, who's getting into the nuts and bolts of it and the human interaction part of it, just informed by different models. Which brings me to my second question, and I don't think anyone touched on this entirely, but I'd like to hear some thoughts on the randomness of humans that goes into the idea of machine learning for health. So you guys are talking about Twitter, so I'll use an example that happened last week where the blue checks were gone and all of a sudden insulin was free and billions of dollars were lost and so on and so forth. no, like I don't really and truly don't, like there's no way your model predicted that. Like that's not something that we can predict. And that happens on a day-to-day basis. I randomly trip back going back to my seat and I get a concussion and I'm out of work. Like there's no model that can predict those things. So just interested to hear what you guys think about that.
Now, who wants to talk about the limitations of prediction, I guess is the question. Zach, you were talking about that. So.
Sure, I'll give it a go. You're absolutely right that, we're predicting the average. We're doing the best we can with the data. And of course, the more data that we do have, the more we can personalize to say, within this subclass of folks, we might be able to have a sort of better prediction. I would say generally we can't predict that chance event, that trip, but people are pretty predictable. I see the same people walking up from the parking lot to work every day. If I want to run into them, I can kind of plan to be there at the same time. And I think, it's really a balance between the patterns that we exhibit every day, taking our kids to school, and those that we can anticipate, and it's predicting those while leaving chance to chance. I'll stop there.
Great. Teresa, we have a question for you. There seems to be a growing pressures for various forms of group privacy, not just individual privacy. How do you balance these pressures against the need for data?
Yeah, and I think that's a really interesting question. It was on my list of things to get to too in the talk. Group privacy is this emerging concept, and I think it's more than emerging now. I think it's actually becoming one that requires serious legislative attention, although it hasn't made it into the sort of the raft of amendments to privacy legislation. So I think that's something to think about. And it's this idea that the way in which data are collected and used now has impacts not just on individuals. So our privacy frameworks focus on personal data and focus on individual consent and focus on what individuals want to have happen with their data. But there's a vast amount of data that's being collected and then is being used to influence decision-making with respect to people other than the data subject. And so that those data that are collected can influence and have impacts on groups and communities, and can even be used to profile individuals who weren't specifically included in the data collection. And so group privacy is a way of talking about how do we ensure that when data are being collected and used in this way, that again there is a kind of social license for the use in these ways, and that those groups or communities are not being disadvantaged or harmed by the use of data that is inappropriate. And so it combines both, I think, human rights considerations and privacy considerations. And the way I see the discussions going, I think a lot of it relates to, again, public engagement, public information, ensuring that people both understand, and by public engagement, I don't just mean information, but actually ensuring that people have some opportunity to provide input into important decisions about how data will be used to inform decision-making in their communities and in their lives.
Great. I'll do one more machine question, then I'll do a bunch of humans. This one is for you, Tanya. Person is asking, given the findings of the Royal College AI report, is there an implementation strategy and is there timelines?
I don't know if my mic is working. Yep. That's a great question. Of course, there's always challenges with fiscal resources and different things like changing CEOs. I can say right now we don't have a complete implementation strategy in place, and which means we don't have timelines. But I can tell you that there remains a commitment to embedding education across all programs around some of these competencies, and we're thinking about embedding those in our competency framework, which is called the CanMEDS 2025, because we think that is at the basis of learning for all of our residents. So that's what we're doing as a minimum.
Great. Go ahead.
So actually, just to follow up on this, is the college position here is that it's okay to hold the physician responsible legally for errors from the AI system?
Yeah, so the college couldn't take a position on that because we don't own the space in those decisions. I can tell you we don't have that. We don't hold that position currently.
Right. Okay. So
we're an education-focused organization, so our position is that we need to train our physicians, those that are going through training as well as in practice, around the legal and ethical implications, but we certainly hold no jurisdiction in that space.
Okay, but you would not be in favor of holding the physician from a liability perspective responsible for errors done by the AI, by an AI system or recommendation system or something like that?
Yeah, I think it's a really provocative statement, but I would not be in a position to represent the Royal College on that view.
Okay.
But thank you.
Can I just say something on
Yeah.
that? It depends, so you can't make a call on that as a blanket statement.
Not at all.
And which is part of why there's a lot of heterogeneity in the nature of the AI and in its application in healthcare settings. So the extent to which the physician is saying, trust me, trust the AI, then the physician will be accountable. So you can't have it both ways, right? If you're saying, well, we're just relying completely on this machine over here, it's the one that's responsible. So liability could be apportioned. The patient could sue the manufacturer, or it could sue the physician, or it could sue all of the above. And liability will be divided accordingly.
And there will be some interesting case law to come, I imagine.
I imagine.
Yeah.
Good. Yes, go ahead.
Not with our friends, though.
Okay. Go ahead.
Hi, my question is for Dr. Kavinsky. So my name is Zira. I'm a master's student at the Heart Institute and also a volunteer for the Kids Help Phone. And so I'm really curious to know if you've considered incorporating your AI suicide prediction tool into crisis text lines. I think that could be really helpful, especially because we have people who are actively reaching out. And also right now, we tend to have long queues, especially at night. And we respond to texters on a first come, first served basis. And so, I'd love to hear your thoughts about that and the applications for your tool in the future.
Absolutely. Well, yeah, thank you. I also volunteer on Kids Help Phone, so it's good to meet a fellow CR. We've thought about the potential of implementing that screening for those reasons. We haven't talked to anybody about it. The other thing is, potentially other AI that might help with, directing those conversations towards things that those people may feel important. We know that for suicidal individuals, connections to life, things that are important for purpose can be important. So other AIs that are designed to leverage what they've put out in the past, social media data, to drive conversations and say, hey, maybe bring up something about music or a pet, to help people. We're looking into that. But thank you for the question. I think it's an important area. And just when it comes to circling back, I was thinking about this with AI. The question is really, we can't do perfect, but can we do better than if we had no information, especially when it comes to suicide. Thank you.
Thank you.
And Catherine, a question I can send your way, being asked, is AI being held to a higher standard than other tools? For example, we don't ask doctors to disclose all the other tools they use. Why do they have to disclose AI?
Yeah, that's a good question. I don't know if you can hear me.
Yeah.
You can?
Yeah.
Okay. That's a good question. I was having a very interesting conversation with someone specialized in tort law, which I'm not, and she said, well, I asked her, throughout all these years you've been monitoring this innovation in healthcare, is there something really special about AI that makes you think that we are in a different zone? And the person said, yes, definitely, and I agree with that. I think physicians don't have to disclose all the tools that they are using, but AI and machine learning specifically, I like the question about the communication issue. So I think it can have an impact, and I mentioned the automation bias, for instance, and the fact that it could be so powerful and so accurate that it will become not only a tool, but it will have a place on its own in healthcare. So I think for that reason, it has kind of a special status that we need to take into account, and I would not, in most cases, put it in the same level as other innovation. Not in all circumstances, but for certain cases, yes, it's different, I think.
Good. Go ahead.
Great, thank you so much. I've been seeing some conversation around modernization of privacy acts, both in Canada and internationally, around whether or not certain population groups' data deserves additional protection. So particularly around a lot of children's data and whether or not that deserves specific considerations in privacy acts. and wondering whether or not what your thoughts are on how that applies to AI in health use. I'm also thinking about Indigenous groups and their historical and ongoing marginalization in the healthcare system, and LGBTQ people who also have issues with the healthcare system.
So that's interesting question. In terms of children's privacy, most of those discussions specifically around children's privacy are in the private sector context. And that's partly because of the business methods that are used in the private sector to harvest information. And I think it's felt that in that context, children require additional protection. So that's what I'd say on that point. In terms of Indigenous peoples, there's significant efforts are being made in Canada to recognize and implement Indigenous, or recognize and participate in the development of Indigenous data sovereignty. And that's a recognition that, for example, First Nations, Métis, and Inuit people have, as a part of a broader sovereignty agenda, rights to manage their not personal, but manage the health data of their communities or populations. And so that's a very different discussion as well, and it's not one that we govern by the modernization of privacy laws, although that can contribute in terms of how it's drafted. But that's a government to government level discussion. And I forgot what the third one was. Oh, just other communities. And I think that's where you start to see issues of not only of categorizing data as sensitive in data protection laws, particularly private sector, but also this evolving concept of group privacy is relevant there as well.
And a related question, there's been a lot of media coverage of algorithmic bias. How machines have been taught the racist tendencies of the people who program them. How do we deal with that? I don't know who's best to answer. Devin, or do you want to answer that?
Sure, I can give some perspective on that. I mean, really, when we are training a machine learning model and we're using healthcare data, the model is learning the practices that are embedded in that healthcare data, right? And so removing someone's, like some innovators will say, oh, I just won't involve race as a data point into the model. That's kind of irrelevant, because that person's experience in healthcare, the types of tests they had access to, their health outcomes, are still unfortunately rooted in their culture, their race, their age, ethnicity, and things like that. And so it's really critical that as we start to build and deploy these machine learning models, we are performing the proper subgroup analysis and bias assessments to understand where are the mistakes happening. You might have a model that's 98% accurate, but if all the errors happen in one particular group of people, that's terrible, right? We might propagate that bias out there. So one of the issues we have in Ontario, I think across Canada, is we don't have in our health record systems that ethnicity data to even do that assessment. This is a huge roadblock that we're facing in at Sick Kids. We're pushing hard internally to get that data. How you ask people for that data is a very culturally sensitive topic, depending on your ethnicity, your race, your culture, your lived experience with healthcare in the past. And so it's not just a simple ask the question and get the answer. Yeah. It's something that's taking a lot of thoughtfulness, but thankfully, people are onto it. And so I think within the upcoming years, we'll see that data coming in. We'll be able to hold innovators to that standard of doing those bias assessments before we propagate these models out to scale.
Okay. We're almost out of time. Well, we're over time, and you guys want to lunch, but we'll let you ask your one last question because you've been very patient.
Okay, thank you. So my question actually fits in with what was just discussed. My sister's a medical trainee, and one of the things I consistently hear from her is that there isn't really one formula that applies to all patients for any problem. Each doctor can take their own approach, and a variety of treatments could work. So when you're designing an AI system to be a treatment method for certain health problems, how do you account for all of those individual differences in patients in responding to treatment? And then on the flip side, when you're obtaining informed consent for using AI as a treatment, how do you navigate the stigma that a patient already has regarding AI, like that Terminator mentality, alongside the power dynamic that exists within a patient-physician relationship?
Mm-hmm. So maybe one of the two clinicians wants to ask.
You want to start? Go for it. Well, I think the part around like an AI system accounting for all scenarios, we know that right now that's not going to happen because we don't have all of the same data going into a machine learning algorithm or an AI system that the clinician would have access to. And so what we're seeing happening is very narrow, specific use cases of machine learning algorithms being built to, let's say, help with interpreting a chest x-ray, right? But that interpretation of the chest x-ray is something that has to be put into this massive context of all of these different clinical data points that then leads the clinician to make a decision. And so until we get to a point where we're actually feeding models, like every single data point that a clinician, like I see and I smell and I touch, and until AI is getting all of that data, it won't be able to actually consider all of these unique scenarios in that context. So that's the first part. And then I'm not sure if someone wants to take on the second part of that question.
Well, I'll take that pause to thank all the speakers and thank the audience for being here. Thank you to Colleen Flood, Devin Singh, Zachary Kaminsky, Catherine Rigi, Teresa Skaza, and Tanya Horsley for being there. And thanks for the really interesting discussion. Thanks.
Thanks, everyone.